Hi, I'm Peter Toth. I'm from Sterling, Illinois, and I'm here speaking at the Best of CHMC series in Atlanta, Georgia. And I came down to talk about HDL. As everyone knows, HDL has become a very complex issue in modern cardiovascular medicine. It's not as simple as the so-called Framingham cube, where at any level of LDL as HDL progressively decreases, risk increases, and vice versa. As it goes up, risk appears to decrease. HDL is not currently a target of therapy, and this is despite the fact that there is widespread agreement among cohorts from around the world on the inverse relationship between HDL and risk of cardiovascular disease. The reason for this is that there have been such a large number of recent clinical trials, including AIM-HIGH, HPS-2 Thrive with niacin, and then 2 CETP inhibitor trials, such as Illuminate and DAL Outcomes, which try to assess the impact of raising HDL on risk for future cardiovascular events against a statin background. As everyone knows, all of those trials were negative. Now, we still hold out hope that 2 newer trials, namely REVEAL with anacetrapib and Accelerate with evacetrapib, will be positive in patients with established coronary disease, but it's going to be another 2 or 3 years before this is sorted out further. In the meantime, there's no question that HDL is a critical component of any risk assessing algorithm, irrespective of the guidelines. If you look at Europe, you look at the International Atherosclerosis Society, the new ACC-AHA guideline, all algorithms use HDL as a means by which to help assess risk. But it ends there. We also know that you should not use niacin to try to raise HDL. Niacin most certainly can be used to reduce the burden of atherogenic lipoprotein in serum. Right now, the name of the game is reducing LDL and non-HDL, and the means by which to do this, I believe, are well established. But we have great reason to have hope that HDL therapeutics will be beneficial because of the very large number of mechanisms by which HDL may potentially impact risk for future cardiovascular events, including reverse cholesterol transport, inhibiting inflammation, oxidation, by inhibiting platelet reactivity. The list is very long, but this is going to take a long time to sort out. Here at the CHMC, we've heard a very broad range of lecture topic on hypertension, lipid management, and the like. And I believe the lectures have been very, very insightful, speaker to speaker. There is lots of concept and a very fair amount of high science, but ultimately, every participant also walks away with a very strong sense of what to do clinically, day to day in community practice. And I think that's the greatest value that these highlights of CHMC conferences have to offer.